Greetings. We're going to get going here. Thank you so much. I am absolutely delighted to be able to be here today to introduce my friend Mindy Fain, which I'll be coming to, but also the fact that we have a very distinguished speaker, Laura Masqueda. Thank you again for being here tonight, who will be talking about elder abuse, causes, consequences, and prevention. I am Kathy Insel. I'm the director of the Innovations in Healthy Aging, and I thank you for joining us for the final Innovations in Healthy Aging lecture of the spring. I also want to give you a very brief overview of the initiative. Some fast facts about aging, and most of these you are very familiar with. By 2030, 1 in 6 people in the world will be aged 60 years and over. Between 2015 and 2050, the proportion of the world's population over 60 years will nearly double from 12% to 22%. And one little statistic I'm very often quoted by saying that in the last decade, we've had an increase nationally in people proportionately over the age of 65, over 32%. But in Arizona, it's 48%. That's a pretty astounding figure for me. I think we are importing older adults, which I'm happy to have, by the way. So the Innovations in Healthy Aging initiative was started in 2018, and it was focused on identifying aging as a critical focus because we have a societal need to prepare our workforce to address issues for older adults. And we also we want to shorten, when we can, as much as we can, the gap between health span and lifespan. So to live as healthy and positively as long as possible is our goal. So the Innovations in Healthy Aging initiative, the primary aim was to influence the critical factors that affect the health of an aging population. I am so delighted to always be with two of my very favorite people in the world, Dr. Mindy Fain and Dr. Esther Sternberg. I often say to people that this is my favorite picture of myself because I am sandwiched between two women who are incredibly supportive and collaborative and have moved this initiative forward. So I want to thank you. They're both here tonight. And I also want to thank Dr. Michael Dake, who's the Senior Vice President of the University of Arizona Health Sciences. He was the co-creator of the initiative at the beginning, and I appreciate his continued support. I must say, I remember a whiteboard many years ago with aging at the center and arrows pointing to so many centers and colleges within our university that influence aging and can be leveraged for aging. I also want to thank the Office of Strategic Initiatives, and in particular, Jane Hunter, Vice President of Strategic Initiatives. And I want to give you a little heads up for the fall classes. We have a lecture series that will continue again in the fall. We'll take a little hiatus here in the summer. But our first talk of August 16th will be nutrition tips. Cardiovascular conditions. October 18th is brain health, and another one in November that we haven't identified yet. I also want to tell you that on the website, which is, if I remember it correctly, healthyaging.arizona.edu, you'll be able to find us there. Thank you, Denitza, for confirming that. You can pull up any of these prior lectures. They are archived, they are on it, but there's also so much else in addition on the website that I am excited for you to take a look at it. Now, I want to introduce Dr. Mindy Fain. She is the Ann and Alden Hart Endowed Professor of Medicine, board certified in internal medicine, geriatrics, and hospice and palliative medicine. She is the division chief for geriatrics, general internal medicine, and palliative medicine, and co-director of the Arizona Center on Aging. a Board of Regents Center of Excellence. She is also the Associate Director for Education, Care, and Community Research for the Innovations in Healthy Aging Initiative at the University of Arizona, and we couldn't do it without her. Thank you, Dr. Fain.
All right, thank you. All right, well, hi, everyone. It is my absolute pleasure to introduce Dr. Laura Mosqueda. And she is professor of family medicine and geriatrics at the Keck School of Medicine of the University of Southern California and the director of the National Center on Elder Abuse. And I was delighted when she accepted our invitation to join us and share her wisdom and knowledge, and I'll tell you just a little bit more about her. She's a geriatrician, just really an exceptional geriatrician, a physician leader who is nationally and internationally renowned for her work to improve the lives of older adults. Widely respected authority on the care of older adults, people who are underserved, and those who know her and know of her work admire her for also her passion, her advocacy in social justice, and that group includes me. And her impact is really palpable on many fronts. No better person to talk about this. At the Keck School of Medicine, she's held several leadership roles. I just need to mention two. She was the chair of the Department of Family Medicine, and then asked to be the dean of the Keck School of Medicine, which is no small feat. She's a clinician, a researcher, an educator, a long-term care ombudsman. She was a prestigious health and aging policy fellow, which will really just help her further her impact, changing the world. She's the principal investigator of 2 NIA-funded studies to understand the causes of and the prevention of abuse in persons living with dementia. So today she's going to speak to us about elder abuse causes, consequences, and prevention. Please join me in welcoming her. Thank you. And I will not walk away with your notes, I promise.
In 1991, I had completed 4 years of medical school, 3 years of residency, and I was in the middle of my 2-year fellowship in geriatric medicine. And a patient came in, and she had a lot of large bruises on her left forearm. A lot. I said, "What happened?" She said, "I fell." I said, "Oh. That doesn't look like bruises from falling." And I gently pushed her a little bit more to ask what happened. And then she broke into tears and told me that her daughter had hit her with a telephone repeatedly. And I was stunned. And I didn't know what to do. So I did what all good doctors do, and I called a social worker for help. And the social worker said, "Well, we have to call Adult Protective Services, APS, to make a report. They're the ones who take a report." Now, I had been through more than 8 years of medical training and had barely heard of elder abuse or Adult Protective Services. And they helped me make a report, and I saw my patient back, and I asked her what happened, several weeks later, and she said, "Well, nothing really." And I thought, nothing really? What the heck is going on? Except I didn't say heck. And I went and talked to Adult Protective Service, like, "What's going on?" And they said, "Well, she wouldn't talk to us." And I asked my patient, "Why wouldn't you talk to them?" She said, "I didn't want to get my daughter in trouble. And I'm already a burden, and I just didn't want to get her in trouble. So I didn't talk to APS." So now I'm thinking, what's going on? This woman is getting hit at home. APS seemingly can't do anything. I, her physician, her primary care doctor, know nothing about this, and I was in a lot of distress over it. So I went to the literature. That's what we do, right? Go to literature and look things up, and my distress only increased because there was no literature. There was no science behind any of this. There was nothing except a few anecdotal reports here and there to help us understand what in the world was going on, how this woman could get hit repeatedly by her daughter, and why we couldn't do anything about it. And as I tried to understand this more, I started riding along with adult protective service workers to see what it was they were seeing and to try and get a better understanding of what was happening. And so I went on dozens and dozens of house calls with these adult protective service workers. And I started to become more familiar with elder abuse and what was going on, and I started to change my practice. I started asking my patients, are you afraid of anybody? Is anybody taking your money without your permission? Is anybody hurting you? And I was shocked that once I started asking those questions, people were telling me about some bad things that were happening. I also started to change my assumptions. I'm very fortunate. I grew up very close to my grandparents, emotionally close, physically close, etc. And so when any of my patients would come in and say, my grandson is moving in with me, I always said, that's so sweet. And they would always say to me, yeah, I know, it really is. But then I started to become more neutral. And somebody would say, my grandson is moving in with me. And I would now say, what do you think about that? And now I started hearing things like, well, I'm a little worried because he just got out of prison. I never heard that before because I didn't realize my own biases going into this. And I had to start changing how I was thinking about things. And I started to wonder, how common is elder abuse? How do you diagnose elder abuse? Why does it happen to some people but not to other people? Why aren't we paying more attention to this issue? And that really launched me on this 30-year journey of my career to try and understand the causes and consequences, and now really working on prevention of elder abuse. And I had this aspirational timeline. I'm going to study this, and I'm going to understand this, and it's going to go in this really nice sequence. And by 2019, we'll have this solved. But unfortunately, it really has been looking more like this. It's very interesting, and this is very similar to a Tokyo subway map. We don't know why, but this is what the actual timeline has been looking like. So I hope that by the end of our talk tonight, I'm going to convince you of three things. One, elder abuse is common. Two, it can happen to anyone, any of us. And the third is that most of it can be prevented. And that's where a lot of my hope is in the understanding and prevention. Before we start talking about these things, I want to tell you a little bit about the different types of elder abuse, because unfortunately there are a lot of different ways that older adults can be abused. We hear a lot about financial abuse, scams, right? Have any of you ever gotten the grandma phone call? Some of you here have, okay. And how does it go? Grandma, you answer the phone. Grandma, Bill? Yes, it's Bill. What's going on, Bill? I'm in a jail in Mexico, and it's going to cost $5,000 to get out. Grandma, don't tell Mom and Dad. They'll be so mad at me. But you have to go, and I'm going to give you the information about how to wire this money. That's a very common scam. So that's one type of financial abuse. But there are lots of other types of people helping themselves to money a little bit too early before this person has passed away. I'm going to get it anyway. I know I'm in the will. And just taking more and more money where people lose thousands and thousands of dollars. There's the emotional abuse. If you don't sign your house over to me, I'm going to have to put you in a nursing home because I just don't understand how we're going to be able to handle things. And I'm sorry, I'm going to tell you about some difficult situations, so I just want to warn you about that. A patient I saw on a house call who had a prized doll collection, and when she was incontinent, her daughter would take over a doll every time she was incontinent and rip a head off of it. Okay? Never touched Mom, but the implication was very, very clear. Physical abuse, people getting hit. And it's just, I think, hard for a lot of us to imagine that this can happen, but it can. And I'm going to tell you another really difficult thing that might be very hard for you to believe. And it's not only that any one of us can be a victim of elder abuse, but any one of us can be an abuser. And we have to internalize that and understand that, and we'll talk a little bit more about it as well. How many of us, and I'm including myself, have been caregivers for people with dementia? Right? Should be about half the room, and it is. So physical abuse can happen, right? People can get kind of annoying, they're following you around, they don't want you to help them do something, you're trying to get them bathed, you're in a rush, and somebody gets hit. Sexual abuse absolutely occurs. I was just called out on a case of sexual abuse that we believe is sexual abuse just a couple of weeks ago, of a woman, though, who was demented, unable to tell us what happened, had all the markings in terms of bruising, wounds, etc., that would make you worry. And the emergency room did not do a sexual assault exam because we don't think of old women in any sort of sexual way, and there couldn't possibly be sexual abuse, but there is. And then another category is neglect. And we don't often talk about it, but you know, if a child sort of recedes from society, you're like, why aren't they in school? What's going on? But think about older adults in your neighborhood who sort of start to disappear and you don't see them, and you don't know what's going on behind closed doors. And so sometimes we see terrible cases of neglect where people are in their own urine and feces, not for minutes or hours, but for days and weeks. People who are getting starved. So there's no active abuse going on, but there is a sort of passive neglect. And the other unfortunate fact is that there's this thing called polyvictimization. So whenever we see one kind of abuse, we're looking for another type of abuse because it's very likely to be there as well. There's a few facts that I'd like for you to know about elder abuse. It's common. 1 in 10 people over the age of 60 will be abused at some point during their lives, 10%. And if you have a dementia, half. Now, I did not believe this statistic, and we actually ended up doing our own study, and there have now been 6 different studies in several different countries looking at lifetime abuse of people with dementia. 50% will be abused at some point during the course of their illness. And that's one of the reasons that this is a big area of focus for me. It hastens mortality, not due to the wounds themselves, but just to be in an abusive environment. And the other thing, you know, we talk about secondhand smoke. There's also secondhand abuse, which is it affects not only the person who's been abused, but everybody who loves them. So in this woman I'm talking to you about that I saw a couple weeks ago, where we're pretty sure there was a sexual assault, her family is absolutely traumatized by what we think has happened here. The majority of abuse is never reported. People don't know how to, people don't want to, people are suspicious of the government. There's a lot, of course, of concern and fear on the part of many underserved and minority communities who are very fearful of what people might do when they come out to the house for good reason. The economic price is high, but the human cost is high, and it happens across all settings. It happens mostly in the community, mostly by adult children and spouses, but it happens in nursing homes, which is where we tend to think of it a lot. It happens in hospice. It happens with end-of-life care. It happens across all settings. A patient I was seeing who was on hospice, we were increasing her dose of morphine because she was in so much pain. She was still in so much pain. We drew a lab to look at the level, and the level was 0. Where was the morphine going? Okay? So it happens across all settings. Now, what is it about growing older that makes us more susceptible to abuse and neglect? And for this, I want to go back to something I learned way back when I was a residency. when I was a resident in family medicine. It was something called the biopsychosocial spiritual model. And the idea behind here is that, there's the physical component, which is what we tend to focus on as physicians. But there's also a really important emotional component to our lives and a social component to our lives, the people around us and our context. And then for many people, probably most people, some sort of spiritual component. And we're not just our physical bodies, the way many physicians have treated us in the past, but we're where all of those things come together. And so this is a model that really rang true to me and sort of made sense, right? But what I realized as a geriatrician is the model looks a little bit different. It looks like this. All of these things influence each other to a much greater effect. And I'll give you a purely physical finding to try and bring this home. If you're a 25-year-old and you trip on these stairs because you go down this middle thing that looks like it's stairs, but it's not, and you break an ankle, that is a bummer. And it will be annoying. And it will disrupt your life a little bit. And you won't like it, but you'll get better. But if you're an 85-year-old and you trip down some stairs and you break an ankle, it's a whole different thing. And this is where I like to apply the biopsychosocial spiritual model, because physically it might be harder to heal. Emotionally, you might end up getting isolated and depressed because you can't get out. Socially, you might start to really withdraw. You're going to have to really worry about what are your social supports. I'm not asking you as a 25-year-old what your social supports are, but I sure am if you're an 85-year-old. You might not be able to attend church anymore, etc. And so we have to understand all of these things and how they influence each other to a much greater extent as we age. Does that make sense to everybody? Okay. And then the other thing that's sort of foundational that I think about is that as our needs change, I know we all love the idea of being, how many people like to be independent? Kind of everybody. But the reality, I hate to break it to you, is none of us are independent. And what I always like to think about is how is it we want to be interdependent? We're a social species. We like depending on each other. We like helping each other. And what I'm always searching for with my patients is appropriate interdependence. How can I help you be appropriately interdependent, and what does that really mean for you? And so if you're appropriately interdependent, you have a certain amount of needs, and then there's ways to meet those needs, and they're in pretty good balance. And sometimes as we grow older, there are changes that mean we have other kinds of needs that begin to grow. And then it can start to get out of balance if you're unable to have those needs met. So I'm always looking at this sort of teeter-totter balancing act between needs and ability to meet the needs. And this becomes key when we're understanding elder abuse. So what are some of the susceptibilities that happen as we grow older? Well, one is physical, right? Our bones, we might get some what's called osteopenia, where our bones are a little less strong, or even into an illness state called osteoporosis. Our capillaries become more fragile. Our skin gets a little bit more fragile. We may have changes in our vision, changes in our hearing. We're not able to metabolize medications the same way as we did when we were younger. So that makes it easier for somebody to get medicated. I remember vividly a house call I was on with Adult Protective Services, and we were seeing a woman who had a painful condition related to rheumatoid arthritis. This was a long time ago when we didn't have the miracle medicines we have now. And she was just kind of out of it. And APS had been notified that there might be some financial abuse going on. And she says to me, she goes, "Check my back." So I look on her back, and she couldn't reach. And there was a patch, a morphine patch on her back. And her daughter would put that on to put her into a delirium and have her sign checks. So she really took advantage of some of these metabolic changes in order to abuse her mom. There are emotional changes as well, right? So it's sort of like a lock and key. Sometimes when you see people who are doing the abuse, they understand that this person is lonely, or they understand that this person is depressed, or that they understand this person wants alcohol. And they'll meet those needs. And in meeting those needs, they then start to take advantage of them in a whole variety of ways. Or they prey upon the fears. You don't want to go to a nursing home, right? Like the story I told you a minute ago, you're going to have to sign this over in order to prevent that from happening. And so people can prey upon the fears. And then there are cognitive changes that occur as well. Now, there's the frank dementia that occurs, for sure. And what I find, and this is anecdotal, I don't have data to prove this, is that in the early stages of the dementia, before it's very obvious, that's when I see a lot of financial abuse because it's easy to manipulate and fool and trick and all that. In the middle stages of dementia, when people might have what are called behavioral problems, resistive behavior, hallucinations, etc., that's when I'm seeing the physical abuse occur. And in the late stages, when you might become bedbound and have a lot of needs, is when we tend to see neglect. So we see this sort of sequence of different types of abuse that occur. But the other interesting thing happening, and this is all credit to my colleague Duke Hahn, who has a lab where I am, and he's looking at people who are susceptible to scams. So we have a questionnaire, and we can tell whether or not you're susceptible to scams by having you do this questionnaire. And we also are looking for people who have been scammed, often who are like embarrassed and don't want to admit it. And then we're putting them in a super duper MRI scanner. We have a very high quality MRI scanner at our school, and finding incredible changes in the brain that correlate with their susceptibility to abuse. Now, when you do cognitive testing, they're normal. There's no dementia whatsoever. But when you do specialized testing for decision making, they're very impaired. So you can have normal cognition the way we normally measure it in impaired decision making. And we can see those changes in the brain, like anterior cingulate. But it's more than just those specific areas of the brain, it's the connections. So, our brain has all these parts that do particular things, but we have all these highways that connect different parts of the brain, and we're seeing a lot of changes to these highways. And finding that even if you're completely cognitively intact older adult, you're more susceptible to abuse and neglect. I tell this to my patients because I want my patients to understand it's not your fault, and it doesn't mean you have Alzheimer's disease, but there are these changes that make us more susceptible. I'm just going to do a quick pause and say, for those people who are like stuck in the sun, if you want to move, it's okay, because you've got some real sun coming in. So if you want to move to a more comfortable seat, please be comfortable. So the next thing I try to think about is intervention and prevention. So the intervention is, you can't intervene if you can't detect elder abuse. So I'm going to talk to you more about that in a minute. And the prevention is, how do we understand it? Because if we want to prevent it, we have to understand what's going on. Now, this is what I heard over and over again. Of course they have a bruise, fracture, pressure sore, skin tear, laceration. They're old. This is what happens to old people. And I started riding around with police a lot on possible elder abuse cases. And I would see an older adult who was bruised. And I would say, my God, this really looks like something horrible happened. And the police would go, well, old people bruise easily. There's no way I'm taking this to the DA, to the district attorney. This is just what happens when you're old. And I had no proof and no evidence for them about why I thought that something bad had happened. And so this is now where some of the research that I'm going to share with you took off, because I'm going, okay, well, why is it I don't think this is normal, quote, normal bruising? And so we did a study where we looked at older adults who had not been abused, and then it took years later to look at older adults who have been abused, and we looked at what kind of bruising patterns we saw in them. Now, I know this sounds like a very simple study, and I will tell you that we use extremely sophisticated methods because we had to look at the colors of the bruises. So I went to the paint store and I got paint chips. And, we had accuracy in terms of what we were calling the different colors. But we had to ask a bunch of people who hadn't been abused if the research assistant could go see them every day for 60 days at approximately the same time of day, plus or minus an hour, get them buck naked and look for bruising. So they weren't like banging down the door to participate in this study, but we had 100 generous people who helped. And here's just briefly what we found, that in people where it was accidental, you saw this sort of bruising pattern, and in people where it was inflicted, you saw this sort of bruising pattern. What are you noticing that makes you more worried about somebody who's been abused? What jumps out to you? Bruising on the head, right? Bruising on the chest more. Here's what happens if you look at their back. Bruising on the back, on the head, on the buttocks, etc. So we're like, hey, there are some ways that you can tell that something is going on. And so this now, we didn't want it just sitting on a shelf, has made its way into emergency room textbooks, nursing textbooks, and the proudest moment of my life, when I recertified for my family medicine boards last year, they asked a question about this study on the boards. And I'm like, all right, and I got it right. But I also want to talk about how long it takes to do these sorts of studies. It sounds simple, but to try and get funding to do it and to go through this process, it was in 1998 when I started doing ride-alongs with police, and it took all the way to 2013 that we published our third paper related to bruising. It takes a lot of work and dedication, but then hopefully you can translate it so that it makes a meaningful difference and actually helps people's lives. So that's a little bit about intervention. You've got to understand and be able to diagnose it if you want to do something about it. So now at least what we can say to people is there are certain patterns that should make us worry about elder abuse. Don't let just somebody walk out of the emergency room with bruises on their face and they just told you that they fell. Ask more questions, find out what's going on, and you can intervene. Because the other thing I'll tell you is I also have worked a lot with coroners. And we started some things called elder death review teams. It was hard to get these going. Why? Because old people die, Laura. That's what happens. You can't flood the coroner's office with every old person who dies. Yeah, I get that, but there's some times when something really bad has happened and we have to look into this. And so we have to understand more of what these patterns are so that we can try and stop it. And when we did these elder death review teams and looked at people who died of neglect or physical abuse, it hadn't been going on for a few weeks. It had been going on for years. And what that tells me is we missed it so many times in our medical systems. We missed the opportunity to intervene when they came into the emergency room, when they came into the primary care doctor's office. I just have been reviewing a case of a woman who died, and a year and a half before this, she had Alzheimer's disease. She came into her doctor's office with bruising and was wearing big sunglasses. And the primary care physician never asked why. But we think you're okay. All right.
I forgot my glasses.
So we have to ask, and we have to at least have a reasonable amount of suspicion when people tell us a story that doesn't make sense about how an injury occurred. Now, the other thing I'm really focused on is prevention. But in order to prevent it, I think we have to understand why it's happening. Now, this is hot off the press, and so I'm going to show you two slides that have just one of our studies on them. And literally, one of my colleagues sent this to me yesterday, and so I added this in. This is a study we have called Better Together. And what we did on this study, don't worry about all the words on it, is we looked at dyads. We looked at people with dementia and their primary caregiver, where there was no abuse. And then we followed them, and we did interviews and followed them at time 0, and then we did it at 6, 12, and 18 months. So it was the first ever longitudinal study looking at abuse. And what we did, because we know that people with dementia, at some point during their illness, half of them, 1 in 2, is going to get abused. So during those 18 months, we thought we're going to at least pick up some abuse. And indeed, we did. And so what we did, just concentrate on the middle for a minute, that little bullseye. We used a model that we developed and published quite a few years ago now, called the AIM model, or the Abuse Intervention Prevention model, where we said, in order to understand abuse, you have to understand the characteristics of the person with dementia, or the person who's being abused. You have to understand the characteristics of the caregiver, and then you have to understand the context of their situation. And we use this model as a framing device for many of our studies and for our teaching and actually for how I even think about it in the clinical setting. And these are unpublished data, so this is not peer-reviewed yet, but I just thought I'd share it with you. And I want you to pay attention to the context and the interaction. And what we found in particular is that, remember that teeter-totter I showed you a little while ago? If the caregiver had unrealistic expectations about what this person could do, they were more likely to abuse them. If she just tried harder, I know she could remember this. If she just tried harder, she could be more cooperative. You know, if he was just more willing to help me, he wouldn't pee on himself all the time. And these unrealistic expectations seem to be correlated with greater likelihood of abuse. The other thing that was interesting is whether or not the care provider felt appreciated by the person they were caring for. And that if they felt underappreciated or unappreciated, they were more likely to be abusive. And we also looked at how close they had been earlier in life. Because, and now this is not an excuse for abusing anybody, but again, I'm going for understanding, not excuse. By the time I see your dad, he might be just a very pleasant person who has moderate dementia, who seems like a really nice guy to me. And now you're going to be caring for him. You, his daughter, typically, we're asking you to care for him. But I don't ask a question as the healthcare provider. I don't ask a question about what your prior relationship was like. Because once I started asking that question, I would hear, he used to beat the crap out of me. I don't want to take care of him, but I have no choice. Hello? That's an opportunity for prevention right there, okay? Those are our opportunities if we ask more questions and ask about prior relationships. If we ask about whether or not people feel appreciated, what their expectations are, we can help, we can intervene in these areas, and I believe we can really help prevent and or ameliorate elder abuse by asking these questions. Are we doing okay? Is this making sense to folks? Okay. This is where my hope is. Like, if we can understand these mechanisms and we can intervene to maybe prevent, like, this is not going to be a good caregiving situation. Maybe let's figure something else out. Or maybe we need to get help at home much more sooner. Or maybe we want to help you with your drinking problem if you're going to be taking care. And maybe it's not the best idea. You know, why is this family comes in, they're all happy, we've diagnosed dad and he has Alzheimer's disease and we know he's going to need care, and we have a family conference and they say, we got this. Susie is going to be able to take care of dad, and we've got this solved because we know he needs a lot of care now. We could leave it at that, but we could ask, why is Susie available? Well, Susie's available because she has schizophrenia and doesn't have a job because it hasn't been all that well controlled. Yeah, no. This is not the caregiving situation we want. The people are trying to solve problems. We're not asking the right questions, and we're not intervening. So this is where I think there's a lot that we can do to help. So how do we protect ourselves and our loved ones from being abused? There's a lot we can do to protect ourselves. Powers of attorney for healthcare and finance, critically important. Have a trust. How many families do we know where they know they've got 5 kids and there's one who's a little like ethics aren't quite what everybody else's are? Plan ahead. So the more planning ahead people can do, the greater protection we have for ourselves from elder abuse. Because we have it in writing, we've gone through the right legal process, etc. Staying in good shape helps protect ourselves from being abused and neglected, the healthier we are. And interestingly, it may turn out that one of the biggest ways to prevent elder abuse is to prevent child abuse. Because there are now some studies showing that children who have been abused are more likely to be abused as older adults as well. So we have to join forces in the family violence universe and help each other with this. There's other things, though, that we can do with loved ones. If you have a loved one who's an older adult living alone, have a list of people to call when they're having problems. They need an electrician, or they need a plumber, or they need a handyman, so they're not just calling somebody and getting scammed. There's proactive things we can do. And we try to do a lot of work with families right around the holiday time when somebody's going to go and visit ma or grandmom, and they haven't seen them in a while, and say, take a look and see what's happening at home, and just do some things that might help protect people. So those are some examples of how we can protect ourselves from being abused and protect loved ones from being abused. Talking about these things is really important. There's still a great hesitancy to talk about living wills or powers of attorney for healthcare and finance, and it's a very important thing to do. And I talk to people about it as just sort of another form of health insurance. But the other thing is, remember I told you, not only can all of us become victims of abuse, all of us can end up abusing somebody else too. And we have to understand when we're reaching our limit. We have to understand when we're getting stressed. We have to be willing to ask for help. Because I will tell you, my belief is that the vast majority of people who are doing abusive acts are not bad people who need to go to jail. They're overwhelmed, they're stressed, they have lost their moral compass, etc. That is in no way an excuse for them to be abusive, but it helps me understand and at least have some empathy and maybe be able to intervene without making them into evil people. All right, we're in the home stretch. Hang in there, everybody. Who is this? It's the boss, Bruce Springsteen. Okay, Bruce Springsteen was inducting this guy, Bob Dylan, into the Rock and Roll Hall of Fame. And he told the following story. He said, the first time I heard Bob Dylan, I was like 14 years old. I was riding in my mom's car. She was driving down a country road, and Blowin' in the Wind came on. And he said, it felt like somebody opened my skull and kicked my brain and just woke me up. He said it was the most incredible experience to hear this song. And the song was done, and they were at a stop sign. And he looked at his mom, and she looked at him. And he said, wow. And she said, wow, that man cannot sing. You know, and so this is, for me, is a nice reminder that two people in the same circumstance at the same time experiencing seemingly the same thing can come to very different conclusions about what is going on. And we have to keep in mind that people have very different perspectives. And what's obvious abuse or problematic to me might not be so obvious to another person. Okay. This is a reminder for me to talk about, we don't want to blame the victim. And we do this very often. Well, they're so difficult, of course they got hit. Well, they're so difficult, of course they couldn't try to bathe them and they were lying in feces. And then we have to ask the right questions. The right question is not how heavy are cats. The question is about all the dents and things that are going on, right? So we have to really think critically and not just, yeah, they're old and they bruise, but what is really going on here, and ask the right questions. We don't always see ourselves as we really are, do we? And so sometimes we think we can do it all, and we're superhuman in all these different ways, but we need to ask for help. And we really need to get help. And we need to understand that we're feeling stressed, even though we may not want to admit it. I'm going to read this sign because maybe not all of it is visible. It says, "Caution, this sign has sharp edges. Do not touch the edges of this sign." And in small print, it says also, "The bridge is out ahead." And this is my reminder to say, sometimes it's the little things that really matter, right? You're looking at all the big shiny stuff. My grandson's moving in with me. Oh, isn't that great? And you don't ask that one tiny question that tells you what's really, really important. Or you're not paying attention to, they have bruises on their forearm. Did you undress them and see if they have bruises anywhere else? We've got to pay attention to everything. We don't want to miss the boat. I think a lot of this has to happen. I'm very grateful that the NIH is beginning to fund more of this, but I think there's really important policy changes that need to happen at federal and state levels so that we don't miss the boat on intervening as we are understanding more and more about elder abuse. This is a picture I took in a small town in Australia. It was by a senior center, and they just had a crossing for aged people. This is, to me, a nice example of a compassionate, sensible, kind thing to do, and that we need a lot more of in this world. And I think that as we're looking at taking care of older adults, abused or not abused, demented or not demented, end of life, or playing pickleball 3 times a day, all of us want certain things in our lives, meaning and comfort and a sense of identity and inclusion, and of course, lots and lots of love. These are the things that every person in our society deserves. And I believe that if we work hard toward this sort of an attitude of kindness and compassion, that we can really prevent the vast majority of elder abuse and neglect that's going on in our world today. So I'll thank you for your time. I hope that I have convinced you that elder abuse is common, it can happen to anyone, and that it can be prevented. Thank you for your attention. We now have 10 minutes of either questions, comments. Feel free to challenge me or ask whatever you'd like. Mm-hmm.
Hello, thank you so much for that presentation. You know, as a third-year medical student who just started my clinical rotations, I can say that I had an experience on my very first rotation where I said, I think there's elder abuse going on. And I called case management, and I was met with, well, do you have the name? Do you have the story? And, you know, I felt a little disheartened, like that I didn't have all of the details, but I had enough suspicion to say, I think we should look into this. And they said they would. So I wonder if there's a way to expedite the process from within hospital systems so that even if those details maybe aren't present in that clinical encounter, and this was ICU, so you can't exactly get all the details, to ensure that these things are followed up on.
Yeah. And I also want to talk about language for a minute that dehumanizes older adults, and even the term case management, which is used everywhere, to me is very dehumanizing because my patients are not a case and they do not need to be managed. I'll leave that aside for just a minute. And your experience is a very common one. And so really, if you look at most laws, our job as healthcare providers is to identify when we have a reasonable suspicion and make a report, no questions asked. It is then APS's responsibility to come in and do the investigation, or the long-term care ombudsman in a licensed facility. The reality is we all do a horrible job of it. And there is a huge amount of variability from APS and long-term care ombudsman, and there's a huge amount of variability among physicians as well. So there's a sense of once we make a report, it's just sort of a black box. We don't know what happens. And I've been begging APS, if you gave us feedback and we knew what happened, and I think there's this false idea of, well, we're not allowed to, it all has to be private. And I think a lot of it could, but we could get feedback. Similarly, physicians, mostly, we're healthcare providers who, in terms of saying this, are supposed to give information to APS and to the police, but we say HIPAA. That's not true. It's not a HIPAA violation when law enforcement asks us, or APS asks us for information, we're allowed to do it. But we so we're each guilty of creating false barriers. And that's one of the reasons we started these things called elder abuse forensic centers, to bring teams together when these sorts of things happened to help move past it. My plea to everybody is, it's going to be a long time before this gets fixed. I will tell you that APS is so much better than it was when I started, and I really see it continuing to work at professionalization, degrees that are required in order to work in this area, willingness to work together. I wish we had the same amount of movement going in healthcare as well to help, and we're gradually making progress, but we cannot give up because we get discouraged and frustrated. You have to be persistent, and you have to be insistent, and you have to be there to advocate for your patient, because you might be the only one there who can do that.
So something that really resonated with me is the comments about caregivers, and being one, and a new one for that matter. My biggest fear is not realizing that I might be causing emotional abuse. It's a fear because I care so much. So I'm wondering, are there services or resources for caregivers so they can be more self-aware and be able to catch themselves or care for themselves in a way so that it doesn't translate into working with my parents?
Yeah, it's so easy to get frustrated and just end up ignoring or yelling or whatever. Just to get really personal for a minute, my father is 91 and has a dementia, and he lives in a house with 24/7 caregivers, just minutes away from me, and I'm there pretty much every day. And the other night, I go over and cook dinner because I like to have the smells in the house. You know, once a week, my husband and I go, we have dinner together. And he has a kind of a mild to moderate dementia. And we would say something, and he would say, "What?" And then we would start to get louder. And then it was like turning into yelling. And I realized, oh, he can hear me. He's saying what because he can't understand and process what we were saying. And so we got really quiet and changed how we were doing things. And I was lucky that I caught that. But it could have escalated, right? So it can happen really to any of us. And so I think the very fact that you're asking that question is self-awareness right there. What we really work toward with caregivers is self-care. Because we're much more likely to lose control. And this is just a brain physiology thing, right? We go to our lizard brains when we're really tired, when we're really stressed, when we're really angry, and that's when we can lose control, right? And you see this with football players. Like, I don't know how we're asking football players to be really angry and aggressive and then just be able to step back and be everything. Like, we don't switch things off and on like that so easily. So caring for ourselves is critically important in all of the categories that I just mentioned. Then there are support groups. Some people hate support groups. Some people love support groups. So it's finding what works for you. And then what I encourage people to do if somebody's really driving you nuts is to just step away from the situation and make yourself a cup of tea or something that takes you away for a few minutes and get your breathing going. I really love meditation. I meditate myself very regularly. And so we might teach breathing techniques to caregivers. But like you said, you have to recognize when that's happening in order to take those breaths in the right way. And I think calling on friends to help you with that is important as well. So those are just a few ideas.
Thank you.
Are laws beginning to catch up to the abuse?
Say again?
Are laws beginning to catch up to the abuse?
Are laws beginning to catch up to abuse? Kind of, sort of. So one of the things that makes research in this really difficult is that every state has a different law related to elder abuse. Most states have mandated reporting, not all. Some consider elders over the age of 60, some say 62, some say 63, some say 65. So you can't do any comparisons. And there is no federal law against elder abuse. So when there might be abuse or neglect going on in a nursing home, they have to use like fraud statutes to go to a nursing home and say you're receiving Medicare funding or Medicaid funding and you're supposed to be providing a certain level of care. They can't go after you because you neglected the person to death. But it can be done at the state level. So it's really confusing. And so most states, every state has some sort of statute related to elder abuse. The question is our willingness to go after it. So just because you have a law doesn't mean you have a prosecutor or a law enforcement agency or a judge who's willing to really hear those cases.
I was just gonna, say, I got married in 1969 for the first time, and my mother-in-law had to bring her mother into her home after her father passed away. And she would get very frustrated. And she was a very educated woman and worked with children to get them that were physically or mentally challenged, to get them up to speed before they ever got to school age, early intervention. At any rate, I remember this, and I don't know why I remember it, but she had a book that she was reading about the effect of caregiving on the caregiver. And it must be an old book because this was early 70s maybe. And I think it really helped. And whatever, I mean, she would come home and she would be working, and then she'd come home and ask her mother, well, why aren't you watching TV or doing something? And then she'd go over and feel the TV, and she was burning a pot, So there was a little interplay between the two of them.
Yep.
At any rate, I think this has been, or at least in my world, a kind of known commodity, but not necessarily in the greater world.
Yeah.
So I don't know, is that a book that
I think you're right. And I think there are a lot of really good books out now that help us understand what's going on. And for people who like to read, we have great books available. The other thing is some really great websites. I love the Family Caregiver Alliance website, for example. Family Caregiver Alliance website has really practical stuff in there, like how you change somebody who gets dirty. I mean, it's everything from physical stuff to emotional stuff. We have a lot more resources now. What I have found is that some caregivers are so stressed and so caught up, the last thing they want to do is hear about a book to read. But if we start to understand more about elder abuse and we can sort of see it coming. See, I'm interested in forecasting it like we forecast the weather. 70% chance of thunderstorms next Thursday. High risk of elder abuse in this family in the coming months. Oh, let's do something about it now before it escalates to that level and make it individualized that works for them. Do you like to read? Do you prefer websites? Can we help you with home health? And do something really individualized, just like what you were saying.
Anyways.
Do we have time for one more question? Sorry, I have somebody here, and then we'll go and then we'll go back to Danitza for our last question. Yes.
Thank you for this talk. This is very enlightening. I'm curious, pre-COVID and post-COVID, have you seen any differences? Have there been any studies? And for me personally, I shared with you earlier, I'm a caregiver too, along with my childhood best friend here, my BFF, with my parents. But pre-COVID, I would swear to you, my parents were going to live forever. They were going to the gym 4 or 5 times a day, walked 2 miles. They were super. They were in their 80s. They were 86 and 87. And I wasn't able to come home. I lived on the other coast for 1.5 years because of the virus, and I was working every day. But when I did came home, when I finally came home, my parents had changed physically, mentally, the lack of movement, the isolation. We talk about that with the younger generation and the loss, but there hasn't been a lot of information about the elderly.
Right.
So I'm curious what your observations are, and if there's what do we do post-COVID?
Right. So we obviously we don't have a randomized controlled trial for this, which is always our preferred method, but we do have observations, and we did publish one article. Mindy mentioned I'm the director of the National Center on Elder Abuse, and we received phone calls, and we saw a real uptake in the phone calls we were getting during COVID. Financial abuse, physical abuse, fear, and all that. So we did see that kind of uptick. And I think you're exactly right, which is people got more socially isolated, more lonely. There were fewer people checking in on them. Everybody was afraid. And now you have somebody who's not exercising, who's getting deconditioned, who's getting depressed. And all of that has extreme health effects, physical, emotional, spiritual, and social. Yeah, you're absolutely right. All right, I think we'll take one last question.
Children have teachers looking out for possible abuse. Who do senior centers have when they're homebound?
Say that again? Who
do senior centers have when they're homebound to report or look for any signs of abuse?
Yeah, and that's a really good point, which is that older adults can sort of fade away and nobody's checking in on them. I've had reports come into a forensic center from postal workers who got worried because they saw somebody in a garage who was being kept there, and not a fixed-up garage next to a car. So we have to rely on communities to help support each other and to kind of keep eyes on to see what we can do to help in these situations, because older adults can become isolated, stop coming out, and people don't think anything of it. Because that's what you do when you're old, right? It's that old thing of grandma goes onto an ice floe and we wish her well. And now we know that's not true at all. Older adults stay engaged in society and add to society, and that we need their wisdom and perspective in order for us to have better societies. And so I think this is really what we're striving for now, in understanding that older adults who are homebound still have a lot to contribute to families and to our communities as a whole. And as we begin to understand that and appreciate that more, I continue to have the hope that we're going to really prevent the vast majority of abuse and neglect that's happening. Well, I really appreciate your attention, and thank you for coming.